Ozempic, aka Semaglutide, Mounjaro, Zepbound, aka Tirzepatide, and then Retatrutide. These weight loss peptides are becoming more and more popular, and there's a lot of confusion about them. And today we're going to break them down, the differences between them, and talking about the benefits, the risks, the side effects, and the drawbacks. Not medical advice. Welcome back, ladies and gentlemen. Dr. Michael Moeller here, naturopathic doctor, doing my best to bring you more health, wealth, and wisdom. If you like the content today, go ahead and give us a thumbs up below. And if I mess anything up or I miss something, please leave a comment below and let me know. If you're new here, hit that subscribe button, stick around. And if you feel like supporting the channel, you can check out our juicy affiliate links. We have some discounts down there on health products and services. Let's jump in. Got a nice little slideshow ready for y'all today. Oh, well, that's not way too far. Oh, now you guys are going to see it all. All right, there it is. Liraglutide, Semaglutide, Tirzepatide, Retatrutide. Benefits, dosing, side effects, contraindications. And again, this isn't medical advice because I'm not your doctor. We're not establishing a relationship here. I'm just giving you guys information only. So what are we going to really break down today? We're going to talk about what kind of expectations you can have using these medications, what things you should be looking at before and after. And then we're going to break them down individually, looking at GLP-1s versus the GLP-1s that have GIP, and then ones that actually have glucagon agonists with them as well. All right, so kind of a basic overview of the more popular ones. Liraglutide, Saxenda was the first one that I heard about. I had a patient come to me who was already using that. And that is a short-acting GLP-1, glucagon-like peptide agonist, meaning it hits the same receptor that hormone does. That is a very short-acting one. It works daily. And then I think that was like 2014, 16. I have the exact information in a second. Semaglutide then came out in the late, like 2017, 2018. And that's a long-acting one. That's Ozempic and Wegovy. And then more recently, Tirzepatide, Zepbound, Mounjaro came out. And that took the long-acting GLP-1 agonist and added a GIP to it, which we'll chat about. And then recently, we have a new one coming out called Retatrutide. I messed that one up a lot. Retatrutide. It's still in trials. And so we have some information about that, but we're definitely going to include that in the conversation today. So the other reason I bring this up, people are like, oh, is that like what Elon Musk was using? Yes. When Elon Musk, this is probably like 2020, 2021, he famously was using Wegovy, lost like 30-ish pounds, maybe 40 pounds. He switched. Then he did switch over to Tirzepatide, specifically Mounjaro. And we'll talk about, like, you have the brand name like Kleenex and Tissue. Like, they're both tissues, but Kleenex is the brand. So you have the brand, which is Mounjaro, and then the generic drug name, which is Tirzepatide. Other popular people using these were the Kardashians. Khloe Kardashian had lost like 80 pounds. Whoopi Goldberg, I mean, it's probably as much as 100 pounds on her. And then, old guy, Charles Barkley, Chuck, man. Yeah, he got on that old good Tirzepatide and lost 65 pounds. I like Chuck. It's a bit of a character. So, yes, I mean, these are becoming more popular in pop culture. Now, pretty detailed slide here about what labs you should run before doing these. Look, I'm a doctor, so I'm going to tell you to do as much blood work as you can. I like more information than less. With that being said, I've known plenty of people to use these before and after. I don't recommend doing that. And then it's not like, look, I'm not expecting you to run all 30 or 40 of these tests. It'd be like $1,000 to $2,000, depending if your insurance will cover it or not. But there are certain things I'm like, man, you really should run. And so we'll go through this list really quick. I'm always running a CBC and a CMP on patients. That's your red and white blood cell count. That's kidney, liver function. In that CMP, you get your fasting glucose, right? These drugs are going to mess with your glucose levels. That's one of the main things that we're trying to manipulate here, because they were at our diabetes drugs, and in diabetes, you have a poor time regulating your blood glucose. You should always watch your kidney and liver function, like a couple times a year. And anytime you're doing some type of new intervention, why would you not do a test before and after to see what happens? These most likely aren't going to mess with liver and kidney function, but you do it anyways. And because we're messing with food intake, you can throw off your electrolytes. And, this will also be important for nausea. And you definitely should run a hemoglobin A1C. All right. Your red blood cells have hemoglobin on them. They are a protein and they live for about 90 days. So the higher your blood sugar is, the way I talk to my patients, it's kind of like if you throw an inner tube in the river. The dirtier the water, the more dirt gets caked on that inner tube. And when we think about this floating around your bloodstream, you have these nice, smooth red blood cells, and you get sugar stuck to them. They're like spikes. And so now you have a smooth red blood cell that's full of spikes, and it's rolling down your bloodstream, and it's cutting up your endothelial lining. It's causing inflammation and all kinds of not fun things. That's why you want to keep your blood sugar down. And your hemoglobin A1C is going to be one of your better markers for watching your blood sugar, because it kind of tells you 90 days, where your spot glucose is really only telling you what's happening in the immediate, like right now, where's your blood sugar at? Wouldn't be a bad idea to measure your fasting insulin before and after. Hopefully you're going to see that go down, right? In diabetes, your insulin has a tendency to rise because you have a decrease in insulin sensitivity. Your body stops listening to sugar. It's just a negative feedback loop. It doesn't listen to sugar. It just, what happens in type 2 diabetes is that your overconsumption of carbohydrates leads to a desensitization of your body to insulin, meaning your blood sugar is rising, but because your liver and your muscles are full, your body senses that your blood sugar is high and says, all right, let's release insulin and let's store that sugar. But then if your liver and your muscle are already full, then your body has to decide, okay, we need to, turn this into fat. And over time, if your blood sugar is high all the time and you keep releasing insulin and your blood, in your liver glycogen and your muscle glycogen are full, your body decreases its insulin sensitivity. So that's why it's important to not overconsume carbohydrates all the time. Having bad sleep decreases your insulin sensitivity. Not exercising. Where on the opposite end, if you go and work out, that increases your insulin sensitivity. So when you eat something after you're working out, your body is more sensitive to insulin. C-reactive protein is an inflammatory marker that comes out of your liver. You should just measure that a couple times a year. C-peptide's it's not necessary. It's kind of helpful for differentiating blood glucose issues in diabetes. I think you should run lipid panels, and more particular, adding apolipoproteins to see where your lipids are running. Homocysteine, this has to do with like B vitamins. It's a marker that goes up. You usually don't want a high homocysteine. It's like bad for your cardiovascular system. Really should run a thyroid panel. Okay, so I don't even know why people would jump on one of these without running a thyroid panel. But thyroid is your body's heat. And if you're cold, like you have low thyroid, cold, constipated, depressed, high thyroid, anxious, fast bowel movements, hot all the time, it can look somewhat mixed. That's a generalization, but like it's really hard to lose weight if your thyroid's goofed. So you should at least run a TSH. I would say you really should at least run a free T4 with that. Free T3 has a shorter half-life. It's debatable. If you have never run thyroid antibodies, I would run thyroid antibodies. You run that once. You might run them every couple of years to double check, but most people, once you run it once, that's sufficient. Cortisol, you can run a morning one, or you can do a 24-hour urine. Just kind of see where cortisol is as far as your stress levels, that it's going to really affect your body's ability to burn fat and maintain muscle. DHEA, I like measuring. It's an intermediate between, right, cholesterol. All of your steroid hormones come from cholesterol, turns into pregnenolone, and then DHEA and many of your other hormones. I like measuring it. I don't think it's 100% necessary, but I would. IGF-1 similar. Like, is your insulin-like growth factor going to go down due to your caloric intake? Iron too, like if you end up being tired, it'd be a good idea just to double check you have good iron storages. You're not going to send yourself into anemia. Same thing with B12, folate. Everyone should run vitamin D a couple times a year. Personally, I tell my patients, if you do 10,000 IUs of supplementation in the winter and you do 5,000 in the summer, you're probably going to be fine. But why guess when you can test? And then ANA, that's a autonuclear antibody. That's a good marker just for looking at general autoimmune diseases. So again, if you've not had that done, it's not a bad idea. And then I put MEH in the category. These are some other hormones that I don't think are necessarily important, that, knock yourself out if you want to measure TMAO, if you want to measure your DHT. It's helpful, but I don't think it's all that helpful in particular with the GLP-1s, maybe leptin, but leptin is usually pretty expensive. Past that, you definitely watch your weight, watch how you're exercising. If you really want to take advantage of using these, you should be counting your macros, your protein, carbs, and fats. At the very least, watch your protein. Get 1 gram per pound of body weight. Watch your body fat percentage. You can do a DEXA scan. You can do like an in-body scan. You can do the old, what are the things that you measure? Someone help me in the comments. I forget the things that they would, the pincher things. And then again, why not measure your waist circumference? You should be watching your blood pressure, your heart rate variability regardless, but specifically when you're on these, you want to see that, and like kind of like with your sleep, are these disrupting your sleep? And then you should have I have a Garmin watch. You should have something that you're watching your steps. It's another very low hanging fruit that will, kind of help you keep tabs. What are some general expectations? This is what actually threw this right into Grok because there's so much information out there. And look, we're going to have some different opinions on this because of the patient samples, the time frame that they're on that. But generally, you can see as the drugs have become newer and they have different mechanism of action, we're having better and better outcomes, right? You're looking at liraglutide, a 5 to 6% average weight loss, which is still significant. If you're 200 pounds, right, 5%, it's 10 pounds. Like that's still pretty good for a lot of people. And then you can see it slowly gets better. The nuance here, like you can see with the semaglutide and the tirzepatide compared to the retatrutide, is that they're shorter. So you can look at that and say, oh, the retatrutide's not as good. It's still in clinical trials. We still don't know a whole lot on it. But you can tell when people are on these for a while, you definitely 20, 30, 40 pounds, depending on your weight, is not uncommon. I don't really like using them for that long. I think you jump on for 3-4 months, maybe go as far as 6 months. There's still some concerns on long-term sensitivity messing with these hormones. People will debate that. That's just my 2 cents. And then I also showed the drop in hemoglobin A1C, which we talked about, right? These were diabetes drugs that people notice, hey, they're really good for weight loss. So if you're pre-diabetic and you jump on these, you can get a 1 to 2% drop in your hemoglobin A1C, which we didn't chat about off memory. 4.8 to 5.7 is normal. Pre-diabetes 5.7 to 6.5, and then over that is diabetic. Hey, where'd my face go? Yeah, I mean they work pretty good. Next slide. All right, now let's get into the meat and potatoes. What is GLP-1? Glucagon-like peptide. This is a hormone that's released in your gut whenever you've eaten food. So you eat food, your gut senses it, releases this hormone, and it says, all right, we got some food. You can stop eating, and we're going to slow down the motility because we need to absorb this, right? So if you eat a piece of bread, it gets digested in your stomach. You're releasing hydrochloric acid and it's jumped into your small intestines, and then you're releasing pancreatic enzymes, you're releasing bile, if it's fat, depending on whatever you ate, like a steak with a steak sandwich. So these things get absorbed in your bloodstream, right? And in particular, let's just say that glucose is sugar. Then your body releases insulin, and insulin tells your body, all right, let's store this. Let's put this away. Let's put it in your liver. We turn it into glycogen, put it in your muscles for glycogen. And so when GLP-1 is released, main thing we're going to see and why these drugs are so effective is just going to decrease your appetite. So you end up tricking your body thinking, oh, I just ate, right? So when you do an injection and this hormone is elevated, or the agonist is the actual hormone isn't the receptor that's being hit, you go, oh, wow, I need to eat. And that works out for a lot of people. My opinion, it's not my opinion, it's science that it is weight loss is just calories in versus calories out. It's pretty simple. The hard part and the more nuanced part is when you are messing with your hormones, how do we manipulate or use those to our advantage? Like I was saying with thyroid, you can lose weight on low thyroid, but you're going to be miserable, right? Like if you have high testosterone and you have massive amount of muscle, your basic metabolic rate is going to be higher. And that's one thing that we have to take into consider when we're using these is you don't want to lose your muscle, especially in the long term. Like if you're over 40, I talk to my patients about this all the time. Like very rarely after 25 does anyone lose weight, does anyone put on muscle. So while we say, hey, you're a 50-year-old and you got on one of these and you lost 20 pounds, but you lost 7 pounds of muscle, I don't want you losing 7 pounds of muscle in your late 50s. As you age, muscle and strength are going to be one of your best markers for longevity. All right. So what are the benefits of these? You're going to have better glucose control because you're not overly stuffing your face. In the short term, having a quick influx of carbohydrates nukes testosterone. There's like one study, it drops it by like 50% in like 60, 80 grams. And the reason for that is you have a high amount of sugar, your blood sugar goes up, you release insulin to drop it. And the idea is that it drops so fast, then you overcompensate, and then you release like glucagon and cortisol to bring it back up. And then cortisol is going to work against your testosterone. So again, this is kind of playing into that conversation about leveraging your hormones. Now, what are we going to do if we have like the vast majority of this is the benefits is coming from just decrease in caloric intake, and in particular regulating your blood sugar. And that's going to reduce your cardiovascular risk in the long term. With liraglutide was the first one I heard about. They actually showed a decrease in carotid artery thickness when they started liraglutide, which is super promising and cool. But again, with lower blood sugar, that's going to be easier on your kidneys. You're going to have a better lipid profile, less likely to get fatty liver, and just going to be overall less inflamed. And that's going to be good for your brain. It's going to be good for your joints. It's going to be good for everything. Alzheimer's, they're basically saying it's kind of like type 2.5 or 3 diabetes of your brain. It's just poor blood glucose regulation. And so it's a good idea to try and keep your blood sugar down, especially from time to time doing fasts. These medications can also be helpful for that because you're going to fast because you're not hungry. One of the other more unique characteristics of the GLP-1 is it acts on the osteoblasts. These are cells in your bones that tells your bones to get stronger. And then also having weight loss is going to be easier on your bones. Now, side effect wise, what are the major side effects of these? Well, you can imagine if you're slowing down your digestion, not going to feel that good. I mean, it's no different than if you just eaten too much and you're sitting around after a meal. You can be nauseous. You can actually have vomiting, diarrhea. You can be constipated. And if you're already having GI issues, pancreatitis, gallbladder issues, this is probably going to exacerbate them. That's probably why you don't want to be messing with these. We'll talk about thyroid issues in a slide or two from the liraglutide. Had some studies on thyroid cancer, which we'll talk about. One of the major things I've talked about already that I'm most concerned about is the loss of muscle mass. So get on that. The other thing, again, in particular with liraglutide, was the worsening of diabetic retinopathy. It's where you have blood sugar regulations and endothelial blood vessel issues in your eyes, right? And it leads to destruction of your nerves in your eyes and being able to see, and you can go blind. And there's some studies that there's some, I think, class action lawsuits where people are trying to sue. If you have diabetic retinopathy, and even if you have probably like diabetic neuropathy, like, yeah, these can probably worsen that. So I'd probably stay away from them. Not medical advice. Talk to a practitioner. I'm not your doctor. But I quoted one in particular study showed a 76% increase in the diabetic retinopathy. The other thing long-term that people are concerned about is long-term delayed gastric emptying. There are people, I think, too, kind of class action lawsuit who are like, I can't eat whatever I want anymore. It's like, you probably shouldn't have been that way anyways. But ultimately, they are like, hey, my digestion slowed down so much. Now I'm uncomfortable when I eat anything. And this is even after coming off of them. The other thing I meant to include in the slideshow I didn't get to was talking about naturally when you're releasing GLP-1, glucagon, and GIP, the concentration of that compared to the drug. My understanding, I don't have the exact stats in front of me, is that these drugs are far, far more potent than your natural production, which makes sense for most hormone replacement therapy. I would just bring that up because then we don't know kind of like long-term, right? We don't really know long-term. Most of these drugs, they've really only been used for like 15 years. There are some people out there who are like, oh, we're really going to regret this. I don't know. I'm not all that. I mean, it's life. Everything, there's risk and benefits to everything. You just have to go with it. And I would think someone who's like 60 years old, it's like, and you're overweight, you're probably better off trying one of these than living into your old age. And not losing weight, because that's going to cause all kinds of issues, just metabolically, heart problems, blood pressure problems, not working out. And so if you use these as a crutch in the meantime to lose a bunch of weight, cool. It really depends. That's why you need to meet with a practitioner and weigh out your risks versus your benefits. We'll break this down. I have on this chart a lot of the different GLP-1 agonists. I just want to highlight a couple of them. Liraglutide 600 was the first one that I knew about. Dosing, drug wise, we'll get into the dosing. That was the first one I remember learning about. And then more recently, the semaglutide became more popular. So I have the dates on there, right? 2010 for liraglutide, semaglutide was 2017. Dosing. Now, again, I'm not your doctor, so chat with your practitioners about dosing. My opinion, I think a lot of people start off way too high on these. And unfortunately, these drugs are very expensive, whether it's through insurance or cash pay. So I think there's a subconscious incentive to get people to go higher because there's larger profit margins. Just my 2 cents. So with my patients, I start them even lower than what these starting doses are at. So something like semaglutide, if you're going to start at 0.25 once weekly, like why not start at 0.1? Why not? Because if you're taking this just to curb your appetite, it's kind of like if you're tired, you're like, whoa, go do a line of, some Colombian Bam or do a cup of green tea first. Yeah, Colombian Bam. Yeah, that's going to get you up and going. But, and I'm not recommending that. I'm just like trying to watch myself. Like, can I say that on YouTube? Or just like a Red Bull. It's like, just start with something like green tea that gives you enough energy. Great. So with the liraglutide, like, why not just start on a lower amount? And what's that? Oh, the oral Rybelsus. I haven't really messed with that one, but I have the lower dosing here, like on semaglutide. Most people are starting at like 0.25 milligrams once weekly, and then they're going as high as 2.4 milligrams. Oral, you're looking at 3 milligrams as high as 14. I don't like going up to those higher amounts, but people do them. Contraindications, like reasons you wouldn't do this: medullary thyroid carcinoma. We'll talk about that in the multiple endocrine neoplasia in the next slide. You got to be careful if you already have blood sugar issues, you're on other diabetic drugs. We already talked about diabetic retinopathy. If you're at risk for already being hypoglycemic, meaning your blood sugar is too low, you've had diabetic ketoacidosis before, like, talk to your practitioner. You can't just be allergic to these drugs. You can be allergic to any drug. So hypersensitivity. If you already have some form of like severe GI disease, I wouldn't know why you would mess with these. Colitis, diverticulitis, Crohn's. If you have hemorrhoids from being constipated, pancreatitis, gallbladder issues, all these things, most likely there's a good chance that the GLP-1s will make them worse. Not always. If you have kidney or liver issues, in general, you're pregnant, breastfeeding, I stay away from them. Heart conditions, the safety is still like not up in the air. We'll talk about glucagon. There seems to be with Retatrutide some concerns there. Maybe not so much with the GLP-1s. If you're frail and elderly, it's like if you're already skinny and old and you're not getting enough calories to begin with, or you have an eating disorder, like, say, probably I would look somewhere else than using these. Basically, in this slide, I kind of just break down those with liraglutide specifically. They had found an increase cancer, medullary thyroid carcinomas in rats and mice. The issue with that is in rats and mice, and the thyroid and the C cells, they have more receptors to GLP-1. So that what happens is GLP-1 stimulates in the thyroid, and then you get a release of calcitonin, and somehow that ends up giving you medullary thyroid carcinoma. Super debatable. So that, and with the multiple endocrine neoplasia, which is also messing with the thyroid, just say, like, dude, stay away. Like, why risk it? Still controversial, but the FDA says, hey, we don't have long-term data. Be careful. I messed up on I have GIP up on this one. We're not into GIP and GLP-1 agonist contraindications. I just also then put drugs, if you're already on some other diabetic drugs. DPP-4 inhibitors, these are it's an inhibitor, breaks down the incretin hormones like GLP-1 and GIP, so you really wouldn't want to stack those together. Taking these is going to slow down your motility and or absorption. So if you're taking like a thyroid medication, levothyroxine, acetaminophen, like Tylenol, you take a Tylenol, it's like, it's not working, I'm going to take another one. It's like, well, it's because your digestion slowed down. It could mess something up, warfarin, contraception, oral contraceptives, antibiotics. Just be aware that this can slow down your absorption of them. And then kind of supplements, you want to be careful. Fiber can make things better or worse. Calcium and iron can mess with absorption. Blood sugar herbs like berberine, fenugreek, and cinnamon, stacking those, those are great herbs for, I think berberine even in itself has a little bit of GLP-1 agonist to it, but you probably don't want to stack them. Again, talk with your practitioner. And then there is something with St. John's wort and the metabolism. I don't think it's quite clear whether or not it messes with the metabolism of the drug, but it's worth mentioning. All right, so now we're going to talk about GIP. And the reason we're going to talk about GIP is because the first drugs we chatted about, liraglutide and semaglutide, were specifically GLP-1 agonists. Tirzepatide, the more newer one, Mounjaro and Zepbound, has an additive effect of being a GIP agonist. And this is another incretin hormone that gets released out of your small intestines. Glucose-dependent insulin-tropic polypeptide. And in all honesty, it does a pretty similar thing to GLP-1. And the main thing that we're going to end up seeing, though, is it just kind of helps reduce the side effects. So it's like, instead of just using GLP-1, you can use less GLP-1 with a little bit of GIP agonist, and you get less side effects. But, you can read on the slides, kind of what I said. I said that stimulates insulin production. Yeah. Oh, the other thing is it has a less effect on glucagon. So again, maybe I should have went over this in the beginning. Like insulin and growth hormone kind of work reversely, right? Cortisol, insulin work reversely, right? Because you kind of have what's called a fed state. You have all these hormones that are going up when you're eating and you have food. And then as you start fasting, these other hormones rise, right? So like glucagon and growth hormone go up when you are fasted, and cortisol for a little bit. And insulin is the main hormone that gets released when you're eating, right? Insulin and GLP-1. So what we're trying to do is trick the body into saying, hey, we're full. But then you can tell, like, if you tell your body you're full and there's no food in there, you're obviously going to get GI issues with that. So what are the main benefits of adding this GIP? Again, it acts similar to the GLP-1. You're going to get insulin secretion. It does seem like there is more so with glucagon, but people just get more weight loss with it. And it does seem like it upregulates fat metabolism. GLP-1 is not going to do that as much. So you basically get this synergistic effect between them. And then, like I already said, most people with tirzepatide versus semaglutide, they have less of the GI side effects, and they're also less hungry. And then, like the studies we showed earlier, less muscle mass, and then you may not have to worry about things like the diabetic neuropathy or retinopathy becoming worse. Main two drugs, Mounjaro and Zepbound, sub-Q injections. Again, most people are starting at 2.5. They're going as high as 15. I think you can start as low as 1 personally, but you do you. Minor difference. Zepbound is actually approved for weight management, where Mounjaro is more for diabetes. So technically, if like you went to your doctor and you were trying to get it covered by insurance, they'd say we go with Zepbound. Contraindications are the same we chatted about earlier. You're slowing down the digestions. You're probably less worried about these though, because we had talked about it's not as potent on the GLP-1. Medical history is going to be the same things I'd watch out for in the GLP-1s. Now we get to Retatrutide. This one is still in clinical trials, and they've added a glucagon agonist onto this. And it's funny because what we were talking about earlier, glucagon is what's going up when you're fasted. So what's weird about this is you're injecting yourself with a drug that tells your body that I am both fasted and I'm both fed. So you use the GLP-1, which is funny because you don't have any food in you. Like, let's just say you're fasting, you do the GLP-1, you tell your body, oh, I have food. But then your body's going to be like, all right, I don't see the blood sugar. Why is our blood sugar not rising? And glucagon will step in there because glucagon is a hormone that when you're fasted, it raises your blood sugar. It basically breaks down glycogen, and then you get gluconeogenesis, which is the process by which your body takes stored glycogen and turns it into glucose, which is in your liver and in your muscle, and it raises your blood sugar levels, which is what you need because your blood sugar can be too low when taking these things. But you want to go into the body and bring that out. And that's the same thing. Glucagon also works on, it triggers lipolysis, which is where your body takes a triglyceride, right? It's 3 fatty acids with a glycerol backbone, goes in there, rips that thing apart, and then you can send the fats into fatty acid oxidation. And so you start burning fat for energy. So super promising. Glucagon's great. It's funny because when I first heard about GLP-1s, I was super confused because of that. I'm like, well, that doesn't make sense. It would make more sense if we were doing a glucagon agonist. And so, yeah, it only took like 5 or 10 years, which glory to God for those people doing the research, not ripping on them. But with glucagon, we'll talk about, there's still like some things we don't really know. We already chatted, right, about its benefits versus the GLP-1s is that it's basically going to go into your fat and tear your fat down. It's going to go in your glycogen and rip your glycogen out, turn it into glucose. And this is what we want long-term, right? We want to burn fat. So it can probably help with like non-alcoholic fatty liver disease. And there are some stuff specifically in younger kids. If you inject too much insulin, like anyone knows, any bodybuilder out there, if you're using insulin for anabolic effects, like you can die. You can inject yourself with insulin and you drop your blood sugar and you can die. Pretty sure most people watching this know that. Maybe not. So you have to be eating something, right? Like I had the story. I remember I had this bodybuilder that I knew. He injected himself with insulin and he went to his locker to get out his food. And for whatever reason, they had locked his locker. And he's like trying to rip. He's like, I need that food now. And he basically told me he smashed the locker in to get his sandwich out because he was afraid he was going to die. So insulin's very dangerous if you didn't know that. And it can be used responsibly. There are people out there like, oh, I use it all the time. Yeah, but don't be a dummy and inject a huge amount. Like people who don't know anything about it, like stay away. Side tangent. But yeah, glucagon, great for, accessing fat for energy. Now, one thing that they are finding out, it does seem like it is increasing heart rate because specifically your heart has glucagon receptors on it. And usually what you can do, you have alpha and beta adrenergic receptors that you can manipulate. Like, right, a lot of people take a beta blocker if their heart rate's too high, if their blood pressure is too high. And so just one slight thing out there for all you biochem or physiology nerds is it seems like even if you block the adrenergic receptors in the heart, glucagon is still able to keep the heart rate up. So may not be good long-term if you have a higher cardio, just like a higher resting heart rate because of this. You're going to get the other things we chatted about, GI distress. I talked about the hyperglycemia. So actually, yeah, you can also raise your blood sugar too high using glucagon. Right? If you shot too much glucagon in you, the exact opposite of insulin, you are basically going in and tearing your fat down and releasing all your glucose, and you raise your blood sugar too high, which is also a bad thing. And you can also get ketoacidosis. So Retatrutide, like we said, it's still in clinical trials. We don't know a ton about it. It seems super promising. Again, starting dose, you're looking at a 0.5 milligrams. Again, I would start lower if you're using that, probably at 0.25. And then you titrate up. And there are people going as high as 12 milligrams in some of the trials. I thought it was dopamine and adrenaline. Adrenal tumor can release dangerous levels of stress hormones. Yeah. So not good. Basically sends you into like a fight or flight response. So definitely want to stay away from that. So if you have a pheochromocytoma, can't even look at it, I have to look away. Glucagon secreting tumors, which would be really rare. I mean, you could have one. And then I think some of these have they have lactose in them. So if you're lactose intolerant, you want to stay away. trust me, Retatrutide took me forever to pronounce. Pheochromocytoma. Ugh. All right, dealing with side effects. We've already chatted about the gut stuff, but what do you do? Like, again, I'm just going to bring up the part about losing muscle mass, right? We have liraglutide over there, 35 to 45% loss in muscle. So if you lose 10 pounds, you're looking at like four pounds of muscle mass. Semaglutide, same thing. Tirzepatide's way lower. I'm assuming retatrutide is going to be better. This is just what I got from Grok. But you know, they definitely are getting better as we go, but you should be mindful of that. And so there are plenty of people who have used these and also not lost muscle mass. They've gone in the opposite direction. You know, if they're on TRT, if they're taking anabolics. So do the basics. Make sure you're getting a gram per pound of body weight of protein. You should be counting your macros and calories. And test your thyroid. Test your testosterone. Make sure that they're optimized. And then you also want to ensure that you're lifting weights. Tell your body, hey, I'm going to lift weights. I want to build more muscle. That's going to help you preserve more muscle in the long term. GI side effects wise, everyone kind of goes about this at a different angle. Most often, if you're having the GI side effects, you can just turn your dose down. Most often, that's usually what you want to do. But then it's like, well, it's like, I have to be nauseous in order to not eat. Well, then I don't know what to tell you. Drinking more water is helpful. Make sure that you're getting electrolytes. You know, lemon water is great. You can do a little bit of apple cider vinegar too, which technically increase in acidity may speed up motility, but, you know, kind of pick what angle you want to go at. Herb wise, I really like ginger. But it's funny because, like we're saying, it speeds up emptying. It increases your motility. So you're kind of defeating the purpose of the drug. But if you maybe just need to take a little bit, not a bad idea. Peppermints also helps with GI issues. And then in licorice, there's an active constituent, DGL, that's also helpful. And like the DGL, you can get in these like little wafer stuff. Like you can get a lot of these in candies, which I prefer versus taking a capsule personally. B6 is a popular one for nausea, right? A lot of times in pregnancy, people are using that. It's not really has a whole lot of evidence in GLP-1s, but a little bit of extra B6 probably not going to hurt you. Worst case scenario, then you end up going with some medications like a Zofran, a Dramamine, hydroxyzine, Bonine. I really don't want to use those. I don't, you know, like an antihistamine is going to make you feel tired most often. But, you know, you do you. All right, that's it. We kind of chatted about everything, you know, the differences, the labs, the differences between GLP-1s, the GIP and the glucagons. That's all, folks. Hey, if you've used these and if you have some constructive feedback, I think a lot of these are pretty new and people are still trying to figure out how to use them dosing wise and what to mix them with. Like I didn't talk a lot about that today. And my guys, we're really going to be putting them on these after their testosterone's optimized. Most of them are on TRT. So they're not going to get a whole lot of loss of muscle mass. They're still going to be able to work out. My 2 cents, you know, adding that. I know other people will be using anabolics with them and whatnot. But, you know, I hope you enjoyed the content today. If you have any thoughts, concerns, questions, please leave them below. Until next time, my friends, stay vigilant and God bless.